Welcome to the 18th SNI and SNI Digital Baghdad Neurosurgery online meeting held on October 23, 2022. The meeting originator and coordinator was Samer Hawes, Universities of Baghdad and Cincinnati. Meeting subject is Neuro-oncology in Iraq. Part 1. The Historical Perspective, 40 minutes. Lecture and discussion, L&D. Part 2, Challenging Cases from Iraq, Personal Experience from two neurosurgeons, 60 minutes, L&D. Part 3, The Update on Neuro-oncology Worldwide, 60 minutes, L&D. The speaker will discuss highlights in history of neuro-oncology with emphasis on practice and research in Iraq. The speaker is Professor A. Hadi Al-Khalili, former chair of the Department of Neurosurgery at Baghdad University.
Hi, everybody. You are welcome here today. We have the 18th Surgical Neurology International Baghdad meeting. This is like 18 months from starting of this event. It started initially as an collaboration between United States and a working team from Iraq, and now we are going extra milestones with each meeting, try to make more collaboration, a wider area to coverage, and the most important, to share experience from different parts of the world. So this is the first meeting that focus on a specific topic, and this is a new trial for us to focus on a specific subspecialty, try to give together what's there in Iraq from background, then what's happening now in Iraq regarding the neuro-oncology, and we have also a guest speaker. We have a guest speaker from the United States, just also to give us a more update on the same topic. Regarding the program, so the first talk will be from Dr. Khalili, and then Dr. Munir, then Dr. Amin, and the last talk will be from Dr. Patel. And through the talks, we will try to have 5 minutes question and answer after each talk. And then at the end of meeting, we can have extended question and answer, opinion, comments. It's according to the topics. So welcome everybody, and I invite Dr. Osman to start the introduction for the meeting.
The meeting subject is Neuro-oncology in Iraq. Part 1, The Historical Perspective, 40 minutes. Lecture and discussion, L&D. The speaker will discuss highlights in history of neuro-oncology with emphasis on practice and research in Iraq. The speaker is Professor A. Hadi Al-Khalili, former chair of Department of Neurosurgery, Baghdad University.
Hadi, you're a towering national figure in Iraq and in the Middle East. Have tremendous respect for you, and can you carry on from here?
Yeah, thanks. Sure. Well, thank you, Dr. Osman, for the introduction and for this great project, noble project, helping people, the young neurosurgeons all over the world, with your leadership, with your expertise, and with creating this SNI International and the Baghdad chapter of it. My talk will be just highlights on history of neuro-oncology with emphasis on practice and research in Iraq. The further backward you can look, the further forward you can likely to see, and that's Winston Churchill. So studying history of the specialty or history of anything is useful really to open eyes for better productivity. I will touch on Mesopotamian medicine, Egyptian medicine, the Greek medicine, Muslim Arabian medicine, medieval and modern times, and then come to Iraq practice. And then also I will touch on the cultural difference of the informed consent. Cancer in Latin means crab, and onco, again in Latin, means tumor. Tumor means swelling, and glia means glue in Greek. In Mesopotamian medicine, we have this wonderful book of Sherlock and Anderson, of about more than 800 pages of the book, which is studying only the diagnoses in Babylonian and Assyrian medicine. No, they don't touch on treatment, just the diagnosis. So in the tumor section, they said, if a falling spell upon him, and it has been falling upon him for 1 year, and at its sign, it comes over him, it's worrisome. If seizure comes closely spaced and in the middle of the day, it will be difficult for him. Another statement about brain tumor in that book, if he is sick with mild headache, and just as an ox continually looks at its own feet and looks at his own feet, that patient will not do well, indicating of gaze paralysis or something. Edwin Smith, in his papyrus about Egyptian medicine, there was no referral to brain tumors, only for cancer of the breast in the Egyptian medicine. I could not see any referral to brain tumors. Hippocrates was the first one to call it carcinoma, which is carcinoma, and it looked like crab. And then Galen viewed cancer as Hippocrates had and considered the patient is incurable after diagnosis of cancer. In the Muslim Arabian medicine, we know that Al-Razas, these leading 3 figures in medicine, and of course there are a lot more, they are leading figures in medicine in the first millennium and just after. And the most important one in our case is Al-Bukhasis, who is Abul Qasim al-Zahrawi, and he was considered by one author in the States that the father of operative surgery. And in this picture, he's showing that he's operating on the head. And he improvised more than 200 surgical instruments, including for cranial surgery instruments. But then later on, Amra Pare, who is considered the father of modern surgery in the 16th century, and then he developed these tools to properly open the head. Then we have Sir William McEwen, who is a wonderful person if one studies his life. And he was the first to perform removal of frontal meningioma in 1879. And in one of the lectures in Glasgow, Harvey Cushing was saying about him, we merely stand on the shoulders of our predecessor, the contemporary figures of McEwen on one side and Horsley on the other side, supporting the arch of modern neurology surgery. So he considers these guys as the pillars. There are so many nice stories about McEwen, his achievement and his work. And then we have Sir Rickman Godley, who was the first to operate on brain tumors in 1884 and diagnosed and operate on this tumor, but was reported in 1885 in this article. The 3 giants of modern neurosurgery are Victor Horsley and Harvey Cushing and Walter Dandy. Of course, there are so many other giants in the book of neurosurgical history of feet of clay and iron, which possibly have seen that book. The important discovery is Marie Curie and her husband, Pierre Curie, discovered radium, and they got Nobel Prize for that in 1903. Their daughter, Irene, and her husband, they artificially created radioactive atoms, and for that they got Nobel Prize in 1935. And I myself used this radium needles when I was a resident for a patient with cancer of the tongue. Now, chemotherapy was started for cancer by Paul Ehrlich, and he got Nobel Prize, while immunotherapy started by William Coley in 1890. And the radiotherapy was started by Emil Gruber in 1896. Brachytherapy in 1966, Mundinger implanted iridium-192 wires into low-grade glioma. And Gerhard Friedlander used iodine-125 implanted in 1979 in gliomas. Practice in Iraq, in general, neurosurgical service in Iraq started in 1946. Mostly was trauma, but then it developed, including tumor surgery and specialized hospital in 1969, and then 1990, and then more centers and developed since then. Our means of diagnosis at that time, in our time, when we practiced at the beginning, was plain radiography and pneumoencephalography, and then cerebral angiography with direct puncture of the carotid artery, and the technetium brain scan, and then CT scan came at 1978. You can see this is the vague picture of the scan, which we was to depend on for surgery of the tumors. Treatment in general, we used to use, of course, biopsy only maybe, or surgical resection, partial or total if possible. And the radiation therapy, we only had cobalt-60, and we put marks on the head, so the direction of the radiation would be on that mark all the time when he come to different sessions. Then we have the accelerator with cobalt, but because of the sanction, cobalt was prevented from arriving to Iraq. So it was only the accelerator, and we did not have any chemotherapy then. Surgery was classical, nothing fancy about surgery. We just used diathermy and loop and very simple means of doing surgery. But then in the 90s, we had the CUSA aspirator, and we have the CO2 laser, and then endoscopy. We didn't have endoscopy, so we used to use this pediatric erythrocystoscopy set to get biopsy from tumors of the brain. In fact, I used this and using the burr hole, which was used before for shunt, which was removed in tumor of the ventricle. And then we had the microscope later on, and we have the navigation of brain lab, which we used, and it was really very helpful. In research, in the European Organization of Research and Treatment of Cancer in Brussels, in 1975, they started multi-center studies in different centers in Europe, and we were part of that group. And we used CCNU and procarbazine and VM26. And these are the part of the form, some of the form which we used to fill, and that is standard for all the centers. And we use Karnowski for rating. And this is the plan of treatment, which I put in my hand in writing, so I can remember how to apply the medication. But unfortunately, procarbazine, lomustine, and CCNU and vincristine were not found to be useful, and they failed to be helpful, and that's in a very big study was done. Especially, it's not helpful in grade 4 and grade 3 glioblastomas. And then Iraq, in the research, we had a paper published by one of my junior colleagues and myself, in the study of 1,287 cases of brain tumors collected over 10 years, and the incidence rate was about 0.09 per 100,000 per year, and the male to female ratio was 1.3 to 1. Another study was only strictly for gliomas, 621 cases, and of those was 417 astrocytoma and glioblastoma and oligodendroependymoma. And it was published, these two papers were published at that time. A study which I've done myself some time ago, not published, and it shows about 1,180 cases, and compared to what is in the USA or and Germany, Japan, Sweden, and India, with some differences between the incidents. In 1985, Iraqi Cancer Board was established, and then we found, and it was a real fact, that after Iraq-Iran war and after the sanctions, significant increase in brain tumors and cancer in general was seen. And this is the population curve of Iraq, and that is the cancer in general, cancer curve in Iraq, which is escalating. In fact, in a meeting in 2000, I was saying that Iraq will have an epidemic of cancer because of the pollution of the wars which we have had. For instance, there is a comparison between 1988 and then 1997, 1998, and 1999. The wars, the pollution was in the 80s and more in 1991 after the Gulf War. So we can see here, these are different provinces. These are the southern provinces which were exposed to the pollution of the war. And you can see the rate of brain tumors is really going very high. These two provinces, they were not exposed to the pollution of the war as much as those. So you don't see that the rate is high in these provinces. For leukemia, just as a sample of other cancers, you can see the difference. In Basra, for instance, south of the country, leukemia was about 5 times more after the pollution of the war, and all this increase compared to the previous 1988 incidents. War caused more gliomas, and that was proved by NIH when they say glioblastoma in the general population is 3.2 cases per 100,000 per year. According to the VA, among post-9/11 veterans, averaged 5.2, while if you collectively Vietnam, Persian Gulf Wars, the veterans, they got 6.2 per 100,000 per year. In another study we had in the Cancer Board, study of 153,132 cases of cancers in detail, and you can see in here how can you get to the details of that study. It's a very elaborative study there. And you can see each year what we have at that time. But of course, this is the low rate because there was lack of good registration at that time. A study of publication by Iraqi researchers from 1942 to the year 2000. That was a PhD project which I supervised with the library special library science professors. The student, she found that in English, there were 662 research articles published by Iraqis, in Arabic, 34, and French 1, and papers presented in international meetings and national, 552 in English, and books were 7 in English and 11 in Arabic. And there is this database is available for anybody to go to. So that was neurosurgery in the past, but now we are proud to see Iraqi neurosurgery catching up and competing with the world-class centers in the specialty with our young neurosurgeons, with neurosurgical leaders like Munir and Samer and many others. The other point I wanted just to end with is cultural differences about the informed consent. Around the world, cancer continues to carry a significant amount of stigma and myths. And they call it that disease. They don't want to name it in some places. Respecting cultural differences without breaching human rights is the important thing to really pursue. In the Western culture, informed consent to medical treatment is fundamental in both ethics and law. Patients have the right to receive information and ask questions about recommended treatments so that they can make well-considered decisions about care. And if the physician failed to do that, he will have problems with the law and with the ethical standard. In Islamic leaders' proclamation, the doctor must be honest in informing the patient, or this is a new thing for the Western culture, or his representative of the disease, its causes and complications, the usefulness of diagnostic and therapeutic procedures, and informing them of appropriate alternatives for diagnosis or treatment. It is not permissible to tell this patient the truth of his illness if that increases the aggravation of his illness. So that is something which is not approved, of course, in the Western societies. In China, there was a Canadian Chinese doctor who went there, and then he was born in Canada, I think, and he went to China and wrote an article about this. And he said, doctors and relatives are primarily interested in protecting the patient, even from the truth. Thus, patients are commonly uninformed of their medical condition, often at the family's request. In Japan, physicians in Japan do not have the legal duty to inform patients of a cancer diagnosis, so they can withhold that from him. Our own experience in cancer, it's really what we have done in the past. I think Munir and others at the moment, they do the same if there is no change in the cultural mentality. We didn't tell the patient that he has cancer. We never tell the patient that he has cancer, unless he is really very, very highly educated and we're responsible. So we choose one of the family members who is really logical and he can take this bad news well. So we tell him separately, and then he will tell the family, and then maybe convey that to the patient in a very gentle way. You are not to tell the patient directly you have cancer and then your life is threatened. So that's what I have, and thank you very much for listening.
Thank you.
Thank you, Professor. Thank you for this talk. I have a comment about that, but I will listen to the panel if they have any comment. Dr. Lazar, Dr. Osman.
Very good talk. I apologize for being on mute, and you should write it up and publish it. It's really very worthwhile for young people and everybody to know the history you mentioned. It was very good. It's very interesting when I was looking at the differences in the cancer just in Iraq, which is obviously a very large country. And I was wondering, are there some patterns there? I didn't see enough to make any difference. I remember going to Peru and listening to a lecture. I was in the audience. Jorge will like this. I was stunned when one of the professors from Peru talked about the increasing incidence of myelomeningocele in poor people. I was stunned to hear that. And because it's obviously meant another factor was involved in the production of this disease, and it had to relate to nutrition. So there are interesting things. The other problem you have with statistics is sampling. We can sample from Baghdad, we can sample from San Francisco, you can sample from different places, but are those samples representative of the world population, or are they representative of just small samples? So we have to be very careful about that.
Sure, yeah.
I personally encountered an experience. I was operating on a general who was in the Moroccan Air Force. He came over with his brother, who was a gynecologist, and his wife. We went to surgery, and after surgery, it turned out to be a glioblastoma. And they told me, you can't tell him. And that was a new experience for me, Hadi.
Yeah.
But yet, what you're saying is true, and it's culturally, it's understandable. And so the young people need to know that they're growing up in a world that has different views about this, and none of those views are wrong. They're what are accepted, and the problem is don't let yourself be persuaded that you're wrong because everybody else is doing it.
Yeah.
If you and your people in your country think it's right, you do it. And maybe other people should do what you're doing. So I had that experience. I was very troubled by it. But that was the culture. And it was like you quoted, if information is going to ruin his life, you can't say that. So I really appreciate what you said. It was a very interesting talk, and I want to thank you. I don't know if some of the other people or the students want to have some questions, but that's, I was really pleased. Thank you.
Thank you.
Thank you, Professor.
I have two examples, Jim, about this. One example, one of our professors in general surgery, he was telling us a story when he was senior resident at the hospital. There was a patient in the nursing home, a medical general, British medical general. He was a patient there, and he went as the chief resident. Out of respect, he has to be the one to deal with that respectable person. He's the doctor and general in the army. So that doctor gave him the history so eloquently and nicely, so he don't need to ask him any question. So I told him I had subungual melanoma, and then which was removed, and then I had lymph node metastasis in my inguinal area, so they removed it with the lymph vessels. And then I had one in the lung, and then probably in the liver. I think I have continuous headache. I think I have metastasis in the brain. And this doctor said I was stunned because he's telling me as if he's talking about somebody else. He didn't show any emotion of being worried or something. So this is one story. And the other story, one of our colleagues who just graduated with us a year after graduation, his father had POO, paralysis of unknown origin, and he went to England to be treated and then diagnosed as leukemia, mild leukemia. And he came doing well with his medication. And then when the family was gathering, the son, the doctor, the physician, read the report in front of everybody, and then he found that he has leukemia, and that this guy was hitting his head and crying, "Oh, my dad, you have cancer." And everybody was really distressed. So we have these two extreme views, as you said, which is right, which is wrong, I don't know, but we have to be careful as physicians when we deal with society. If we are here, we have to abide by the law. If we are in Iraq or somewhere else, we have to really respect the culture. Thank you.
Any questions? Jorge?
Yes, no, I have one other question. This issue is with cancer or with any other patient? I mean, if you have a patient with a Chiari, if you have a patient with any other disease, craniosynostosis, VP shunt, you also talk to the family, or it's only on cancer that you are selective in not telling the patient the truth about this condition?
Thank you for this question. It is for cancer and cases which possibly will end in death, or very terminal cases, or very difficult cases to treat. Not only cancer, but cancer will be the top of the list. But these are not craniosynostosis. You have to talk exactly what you have in mind. But those which deal with the end of life, these you have to be careful with.
Yeah.
I remember when Jorge was head of pediatric neurosurgery at UCLA. he would receive patients from South America. And some of these patients had very difficult problems to treat. And it was his decision not to send them home with a deficit because the family would not understand it, the population wouldn't understand it, the person wouldn't understand it. And I know that he was encouraged and criticized because you didn't take everything out and leave the patient paralyzed. So the answer to the students here and the residents is science is wonderful, but we're dealing with people and humans and emotion.
That's right.
And those are very important considerations. So that's the message from your talk, Heidi.
Yes, sure.
Yeah, I agree with you.
Dr. Patel?
Thank you. Thank you, professors. Do you have any other comment?
Dr. Patel has her hand up.
Yeah.
Munir or Dr. Mahdi or Dr. Patel, any thoughts?
Thank you. I'm preparing my next presentation.
Okay.
Yeah.
Dr. Mahdi? Any thoughts?
Yes, it depends on the age of the patient, because we are not telling the old guys, like those are above 60 or those that are kids, we don't tell them the diagnosis. But for those that are 18 years and more, they came with, they have read the MRI report or the CT report. They know the diagnosis. They have read online and join groups on Facebook that discuss the treatment options, the surgery, the consequences. So it's a new thing now. It's a new era. It's in the area of the social media. In the online era, the internet, everybody can access many of the informations, and they come to the clinic. They ask you what you are going to do. Are you going to do gross total resection? Is it possible? Is it not?
That's
Very good point. Very good point. I'm 84 years old, going to be 85 years old in a couple of months. And I've had 4 cancers in over 40 years. So it can be age, it can be determined by age, but age is not necessarily the only determinant. It's physiologic health.
Yes, sure. Yeah. But because here in Iraq, they bring the kids, the children, their parents will talk about them. But for old guys, their boys will talk for them. They say he don't know the diagnosis. We don't want him to know the diagnosis. Tell him that he has a cyst in his brain and they need a surgery or an infection or whatever, but don't tell him the diagnosis.
Yeah.
It makes it very complicated for the doctor, but you're absolutely right. Okay. Anybody else?
See the hand of Dr. Patel up?
My hand is not up, but I think, I listened with interest to all this conversation. It is an interesting balance between paternalism and the sort of free dispensation of knowledge that happens now. And it's sorry, my children are here. My husband's on call, so there's 3 young kids in the house, but it is an interesting balance now between paternalism. The Indian culture has so much of this also, and this need to sort of protect the elderly and the youth from diagnoses that might be disconcerting or emotionally troubling for them to handle. And so we should, sort of take that on as physicians and dispense knowledge as we find appropriate. But on the other hand, as Dr. Mahdi said, young people now have access to the internet. They know all about what's going on with their bodies, oftentimes before they come to the physicians. And so if you're not upfront with them, then they think that you're deceiving them or keeping something from them, and it's hard to form a trusting relationship in the modern era. Whereas 50 years ago, maybe people would have accepted what their physician said carte blanche without without question. And so I think it's a really hard thing to navigate, and particularly in Eastern cultures, including my own, where this element of trying to protect your family members is a very strong feature.
Yeah.
It's a terrific discussion for, imagine when this video gets up on SNI digital and the whole world can see how how this problem is approached differently, and no one's wrong and no one's right. It's all right.
All right. Yeah.
Yeah. Thank you, professors. I would have a question for Dr. Khalili.
Yes.
Maybe the last question for this, then we have the next talk. What's your vision for the oncology wise, I mean neuro-oncology wise, for the next generations? What do you think how you imagine the next era for Iraq, neuro-oncology wise, and advice wise, or in expectation wise?
Well, I think in general, in neuro-oncology, in the future, Dr. Osman, he spoke about this last time very eloquently, and then he told us a lot of the new advances and the expected advances. In our country for neuro-oncology, I think this is the responsibility of Dr. Munir and his colleagues, just to encourage young neurosurgeons and young oncologists to go to this line, which is very important and essential. Now it's established, neuro-oncology is a specialty of its own. Nobody can interfere with the treatment they recommend, neither the surgeon nor the radiotherapist. So they have their own say. And we hope it will be, there will be a subspecialty of board within neurosurgery of neuro-oncology. That's my hope.
Okay.
We hope you enjoyed these presentations. This series is supported by the James I. and Carolyn R. Ausman Educational Foundation, owner of SNI and SNI Digital, and the Waymaster Corporation, producers of the Leading Gen television series, Silent Majority Speaks, Role Models, and Medical News Network. The recorded session is available free on SNIdigital.org. Send your questions or comments to Ausman at SNIdigital.org. Thank you.